Enamel, highly calcified, hardest, crystalline in nature because of calcium phosphorus bonds. Enamel rods. Insensitive, no nerves, acid soluble below 5.5, cannot be renewed, darkens with age. Fluoride and saliva helps remineralization because they protect it, and then remineralization can occur. Enamel. Enamel is lost by physical and chemical dissolution. Physical was abrasion, attrition, abfraction. Chemical was chemical erosion, abfraction lesions. And then there was dentin, which is softer than enamel, does not have nerve supply, but closer to pulp. They had dentin tubules. How it was sensitive? There was not direct nerve supply, but it was sensitive because of the dentinal tubules produced throughout the life, so it can be regenerative. So dentinogenesis can take place, and there were three classification: primary, secondary, tertiary. Primary is the outermost, causing the where is it? Primary is the outermost, causing the primary is the outermost, causing the shape, making the shape of the teeth. Secondary was next to primary. Tertiary was innermost and reparative, because they why it is known as reparative dentin, because it contained odontoblasts. And there were two types of dentinogenesis: important, reactionary, and reparative. Even if you know this much, that would be more than enough for now. And then there were dentinal tubules containing joining the dentin with the pulp, containing the fluid known as dentinal fluid, which was a hydrodynamic movement, because it can result in short and sharp pain episode on the provision of external stimuli, which is a little bit harmful or more than usual stimulus. They were parallel to each other, contained fluid known as dentinal fluids and nerve fibers, which were the nerve endings of the pulp nerve tissue. And then we had dentinal tubules more. They were directly associated. The hypersensitivity of dentin was directly associated with three things: when it is open and patent tubules, which contains two factors: either the dentinal tubules will be greater in number, or it has larger diameter or more open. This will result into dentin hypersensitivity. Other than these, there was removal of smear layer, outer layer, and erosion or tooth wear can also help in hypersensitivity or pain. Otherwise, erosion or pain, which can help in erosion and form a dental cavity. What is the smear layer? If someone asks, any layer outer to dentin will be a smear layer. It can be enamels layer. It can be anything. Okay. Cementum. Now we go to the cementum. So where cementum here is, if you see the alveolar bone, this is the alveolar bone, right? This is the all of it is alveolar bone. So alveolar bone, next to it is periodontal ligament. Peri, surrounding what? Odon, tooth or teeth. Periodontal ligament. Why not tendon? Why not ligament? What is the definition of ligament? Anyone?
It's attached bone to bone.
To bone.
And what is the other? Tendon.
Tendon attached muscles to bone.
So why this one is ligament? What two bones are being attached? Please, why this is periodontal ligament? Why this is ligament? Anyone? It's okay, make mistakes, because it's joining alveolar bone. Yes, please continue.
It's joining alveolar bone to the teeth. So.
Yes, perfect. Okay. So yes, that's why it is known as periodontal ligament. This is known as odontal ligament because it joins the alveolar bones with the teeth. It's the teeth sockets into the alveolar bone. And why peri? Because it surrounds the teeth, the whole root of the teeth. Okay, that's why periodontal ligament. That's how we remember. So periodontium contains cementum, alveolar bone, and periodontal ligament. This is periodontium or periodontium. This is a structure containing of three structures, three components. Outermost is alveolar bone, and then this purple region is cementum, which is more towards the which part? Teeth part. What is this? This is dentin. Towards the dentin is cementum. Towards the bone, outer to cementum is periodontal ligament. So now we are talking about cementum, a thin layer of mineralized tissue. This is also mineralized tissue covering the dentin. We remember it was hard tissue. But now we also remember that it's softer than enamel and dentin. So enamel, the hardest mode, then there is dentin, and then there is cementum. According to the relative hardness or rigidity of the structures, enamel is most and cementum is the least hardest of the three, right? So much so that enamel was one of the hardest tissue of the body. Perfect. And then what happens? What does cementum do? Anchors the tooth to the alveolar bone along with the periodontal ligament. So cementum along with the periodontal ligament attaches or anchors the tooth in the socket of alveolar bone. Not sensitive. As you see, there is no nerve cavity between them. That should not be sensitive. Sensitivity starts here, pulp area. Sensitivity starts here in the pulp area, right? We have nerve endings in the dentin. So no sensitivity here in the cementum or periodontal region. Next, I'm trying to make sure that you remember as much as you can in the class. Okay, so this is cementum. Now again, so here we have alveolar bone. Starting from the alveolar bone, we go towards this. And then there is periodontium, right? And then periodontium was a layer containing fibroblast and cementoblasts. Fibroblast for the repair, they have collagen fibers, and then there is Sharpie's fibers all the way into the cementum. And then we have acellular cementum and cellular cementum. How to distinguish more the cells? We have cells, then it is cellular cementum. When we have fibers, then there is acellular cementum, no cells, right? Relatively less cells. There are absolutely some cells here, but relatively less cells. So acellular cementum and cellular cementum, and then this is a junction between cementum and dentin, known as cementum dentin junction, and then the dentin starts, and then there is predentin. The cells of cementum must be known as cementocytes. No big deal. Cementocytes, cells of cellular cementum. And then we have next to that in the periodontium, there will be cementoblasts, immature cells from which cementocytes can form. Excuse me. And then if we see periodontium here, this is the whole structure. Okay, let's go to the next. Okay, this yellow highlighted region, the yellow highlighted region is the cementum. Okay, next. Now we go for the dental pulp, the last one. So let's go from the outside. We had enamel, outer hardest layer, calcified layer, enamel. Next to enamel, we had dentin, this highlighted orange area. And next to dentin, we have cementum, this cemented area, right? Okay, and then there will be pulp, cement, and then there is pulp. This pulp is also known as dental pulp. Okay, the innermost part of the tooth. Now we know this is the innermost part of the tooth, basically the dental tissues, we should say. It's a soft tissue, as we remember, enamel, dentin, and cementum were hard tissues, so that enamel was more hard than dentin and cementum, and dental was softer than enamel but harder than cementum, and cementum was softer than both of them. But this dental pulp is a soft tissue with blood vessels and nerves. So we have blood vessels and innervation here, responsible for nourishment of tooth, because blood vessels, because of blood, we will contain the nourishment, nutrients, oxygen, carbon dioxide, take out, and everything. So it helps in the nourishment of tooth. The pulp in the crown of the tooth is known as coronal pulp. So this pulp, which belongs to the crown of the tooth, is this crown. This is the crown, and up to this part, the pulp is known as the coronal pulp, the crown area, right? And the pulp canal transfers the root of the tooth. So this canal transfers the root of the tooth. So if this is the root, so the pulp canal is going in the root area. Typically sensitive to extreme thermal stimulation. Thermal means change in temperature. Extreme means either very hot or cold, right? So it is typically sensitive to extreme thermal stimulation, hot or cold. So when you feel it's very cold or hot, so that it pains, it is disturbingly cold, it's disturbingly hot, then involved. Okay, next. So the role of tooth pulp: aids in sensory function. This is called, helps from form dentin because of odontoblast layer and predentin, and provides tooth moisturization and nourishment because of the blood vessel. Aids in sensory function because of the innervation. Helps form dentin because of the odontoblast layer and predentin, and then provides tooth moisturization and nourishment because of the blood vessels. Perfect. Okay, now dental pulp, we study something about it. Pulpitis is the inflammation or infection. Pulpitis is the inflammation or infection of the dental pulp. Pulpitis, pulpitis. Inflammation or infection of the dental pulp causing extreme sensitive or pain, or we should say disturbance, right? Extreme disturbance, more than usual, more than normal. Pain is derived as a result of dynamic stimuli. You know that activating mechanoreceptors, mechanical in the nerve fibers of the superficial pulp. These fibers are alpha, beta, alpha delta, and C fibers. Alpha beta, alpha delta, and C fibers are present, are the fibers in the superficial pulp, and the nerve endings have mechanical cause as a result of hydrodynamic stimuli. Hydrodynamic stimuli include thermal, temperature related, that's hot and cold; tactile, tactile means movement related; evaporative; and osmotic. These stimuli generate inward or outward movement of the fluid in the tubules, dentin tubules. We are talking about dentin tubules, and activate the nerve fibers. You remember the fluid, dentinal tubules had dentinal fluid, which had the nerve fiber from the dentin, and dental pulp. Dentinal tubules were across the dentin, and this is the pulp area. So dentinal tubules were present in the dentin, and dentinal fluid was present inside, and the nerve fiber from the pulp was up to the dentinal fluid. Alpha beta and alpha delta fibers are responsible for sharp pain of short duration. The sharp pain of short duration is by alpha beta and alpha delta, whereas C fibers are dull, throbbing pain of long duration. So alpha beta and alpha delta are in the start. So A, B, C, D will be cause sharp pain of short duration, but C fibers, C is a sea of water, is big, is long, right? So it causes dull throbbing pain of long duration. Okay, pulpitis may be reversible, treated with restorative procedures like root canal and everything, necessitating a root canal treatment. So cavity formation, and it involves all deep down to the pulp. We will study later in the lectures. Then the teeth cannot be saved, then we need RCT, root canal treatment. But if it is reversible, we can cause some restorative procedures, remove the plaque, remove the caries, remove the bacteria, clean it, give some medicine, cover it, cap it, molar cap, something. Untreated pulpitis can lead to pulpal necrosis necessitating root canal or extraction, or even extraction when the teeth is completely empty and dead. There is no other procedure than extraction. But if the patient wants, if it's frontal teeth, it's not, it's anterior teeth, and it looks cosmetically bad, then you can do the root canal and then cover the tooth. Maybe a lot of students already know these, already heard these terms. So this is the stages of tooth caries. There is tooth staining. Bacteria love this. Bacteria start enamel erosion. So this is known as enamel caries. And then it reaches to the dentin, dental caries, and it reaches to the pulp, pulpitis. You don't take care of pulpitis, all the periodontitis take place, all the periodontal tissues are involved. Periodontitis. Perfect. Pulpitis starts with an injury to the tooth. Tooth decay, enamel erodes, dentin erodes, reach to pulp. Pulp has blood vessels, pulp has nerves, nerve cause pain, blood vessel will cause bringing of the inflammatory cells, causing an inflammatory response. So which bacteria are most common in causing pulpitis? Mutants, group streptococci, for example, streptococcus mutans, and then there is another streptococcus sobrinus. Remember, at least remember mutants. One of the favorite question of examiners. Okay, now we go for the periodontal tissues. What are periodontal tissues? I have written a mnemonic here. Gaps. These are tissue in the gaps. Gingiva or gingiva, alveolar bone, periodontal ligament, cementum. Here, this one is hard, and this is hard, and these are soft. So two hard tissue, two soft tissue form the gaps, periodontal tissue. Gingiva and periodontal ligament here and here as soft tissues, and alveolar bone and cementum is a hard tissue. Perfect. Here we have gingiva or gums, gingiva. Then there is cementum. In between them is periodontal ligament, and then there is alveolar bone. So we have four. The other one was 4 important dental tissues. Do not confuse. Let me go back. These were just 4 important dental tissues, 4 main dental tissues: enamel, dentin, cementum, dental pulp. But if we talk about a structure, a group of tissues known as periodontal tissue, this is a structure. This is formed by gaps: gingiva, from outer gingiva or gingiva, alveolar bone, gingiva, and periodontal ligament and cementum. These are periodontal tissues. Okay, gingiva. The part of the oral mucosa overlying the crowns of unerupted teeth and encircling the necks of the erupted teeth, right? So if the teeth are unerupted, still inside the gums, they will cover the crowns, the upper part. And if the teeth are erupted, they will cover the necks. And necks, these are the necks, this is the crown, this is the neck, and root is inside. So this support the neck of the erupted teeth, serving as support structure for sub-adjacent tissue. This act as support. Alveolar bone, also known as alveolar process, the thickened ridge of bone containing the tooth sockets in the mandible and maxilla. So just need to remember, is alveolar bone is a part of mandible and maxilla which provides the socket for the teeth. Okay, here we have 2 types of gingiva, free and attached. Free have interdental papilla, interdental between the 2 dentum teeth, and then free gingival groove. This groove is known as free gingival groove, and then this is the part of free gingiva. And then attached gingiva is this part which is attached to the alveolar mucosa. This is interdental depression. This is interdental papilla, and then there is mucodental mucogingival junction. This boundary is mucogingival junction, and then this is inferior labial frenulum. So this should be mandible because it's lower jaw, and because we have inferior labial frenulum. Okay, and then again interdental papilla, interdental depression, interdental grooves, frenulum, alveolar mucosa. In the diagram showing dental tissue, gingiva, and alveolar bone. Now, periodontal ligament and cementum, you already know. Periodontal ligament connects the cementum of the tooth root to the alveolar bone of the socket. This is a ligament connecting two bones, which is alveolar bone and the teeth. Cementum is bone-like, rigid connective tissue. Is bone-like, but is not bone. Is bone-like, rigid connective tissue covering the root of the tooth from the cemento-enamel junction. What is cemento-enamel junction? This is cemento-enamel junction, where enamel and cementum starts. This is cemento-enamel junction. I have made a quite large, but it should be this. Okay. Bone-like rigid connective tissue covering the root of the tooth from the cemento-enamel junction to the apex. This is apex, right? Root. And lining the apex of the root canal. This writes apex of the root canal. All the way. The cementum goes down all the way. You remember the cementum, right? It also serves as attachment structure for the periodontal ligament, thus assisting in the support of the tooth or tooth support. Easy. Okay. Next, anatomy of the tooth. In short, you can read by yourself. We have, thanks to Netter, we have incisors, lateral, central, and lateral, and then canines, which are cusps, unicusps, or you should say cuspids, one single projection, premolars, at least bicuspid, at least have two projection, and then molars, multiple projection, polycusps, and then this anatomy. Crown, neck, root, enamel, dentin, dental tubules, all of the anatomy. Okay, so an environment of oral cavity. If we go to the environment of oral cavity, we have, it includes plaques, saliva, pH values, demineralization, and remineralization. We quickly go for the plaque. Plaque is a biofilm. What is this? Is a biofilm. We are talking about the environment of the oral cavity. Plaque is a biofilm. And then it is formed, if you don't brush the teeth, it is formed by the bacteria and the sugary reaction, and then contains more than 600 different identified species of bacteria. We are not talking about unidentified. So we know at least 600 different identified species of bacteria in plaque, which is a biofilm. These bacteria, when they get sugar, food, they secrete the plaque. There is harmless and harmful plaque. So we have two types of plaque, harmless and harmful. Nevertheless, you need to remove the plaque by brushing the teeth every day. Slippery pellicle allows the bacteria to adhere to the root tooth surface. Come on. Okay. Salivary pellicle allows the bacteria to adhere to the tooth surface, which begins the formation of plaque. How the plaque is formed? By the salivary pellicle, which allows the bacteria to adhere to the tooth surface, and then bacteria secretes plaque. Okay, next. So this is dental biofilm, healthy tooth, and tooth with biofilm, plaque. So what is the difference between plaque or tartar? Tartar is also known as calculus. So plaque, there will be fizziness of teeth, bad breath, halitosis, gum redness and tenderness, and potential bleeding while brushing. But tartar, roughness on teeth, swollen gums, prone to bleeding. So this is a distinguish between plaque and calculus or tartar. Okay, you should remember this. Is important. Saliva, a complex mixture of fluids, perform protective functions. You know, they lubricate, which aids in swallowing of food. They help in mastication, which mixing of saliva with the food. Key role in remineralization of enamel and dentin. And they help in buffering, pH buffering. So we have parotid salivary gland, we have sublingual salivary gland, and submandibular salivary gland, and the ducts of which we have studied in the anatomy of oral cavity. pH values, you already know a lot about this. They measure the acidity, the measure of acidity or alkalinity of a solution or basicity of a solution is known as pH, measured on a scale of 1 to 14, where 7 is neutral and less than 7 is acidic, towards 0 being more acidic, and alkalinity as increase, it is more basic. So towards the neutral is least acid and least basic, and these are some of the acidity and basicity of alkalinity of the things. Here, important to know, we have black coffee at 5, milk at 6. Milk is more acidic than it should be basic, and then because of the bacteria, and then pure water at 7. Here, this is the zero level, or you should say comparative comparison with the, we make the comparison with the water which has 7, neutral. The pH 7 indicate the solution is neutral. The pH of mouth is close to neutral. It's not neutral, but it's close to neutral until other factors are introduced, like any acidity or basicity or alkalinity. What is the difference between basic and alkaline? When base is with water, with a solution, with the solvent, is known as alkaline. Okay, pH is a factor in demineralization and remineralization of enamel or dentin. As you remember, enamel pH less than 5.5 will cause demineralization, and for dentin, pH 6.5 less than 6.5 will cause demineralization of dentin. So pH is a factor for demineralization and remineralization of dental tissues. So we had demineralization. Mineral salts dissolved into the surrounding salivary fluid. Enamel, if it is more acidic than 5.5, it's lower acidic, pH is lower than 5.5, enamel will salt demineralization, and pH lower than 6.5 for dentin, it will cause demineralization. So how it is demineralization is caused? There will be pit and fissure caries are around the deep grooves of premolar and premolars. Interproximal caries are cavities that form on the sides of our teeth. They are more common, this cavity, interproximal. They are more common in patients who do not floss. Smooth surface caries are among high risk patients who do not disturb the biofilm plaque along the gum line. So there are 3 types: pit and fissure. Pit and fissure caries, interproximal caries, smooth surface caries. Okay, erosion or caries can occur because of the demineralization. Why we have studied caries? Because of the demineralization, erosion or caries can occur. Pit and fissure caries, interproximal caries, and smooth surface caries are some of the caries found because of the demineralization. And then we go for the demineralization versus tooth erosion. What's the difference? Healthy tooth erosion, tooth demineralization. Tooth is also demineralization. Remineralization is found when pH backs come to normal or neutral, close to neutral. Saliva rich with calcium and phosphate remineralize it. So calcium comes out, phosphate comes out because of the bacteria or any reaction, demineralization, and then when calcium and phosphate come back, when the pH is normal, there is no bacteria causing caries, it will cause remineralization. Enamel pH above 5.5, dental pH above 6.5 will cause remineralization, because minerals now can penetrate easily in the damaged enamel or dental area because of the higher pH. Again, a comparison between it. So this is a dynamic process. The demineralization and remineralization are taking place at all the times. It's a dynamic process. So we have to put it in balance so that it should either not be acidic or not be basic. Dental nomenclature. So we have 5 minutes remaining. Dental nomenclature is easy. We will start in tomorrow's lecture, but tomorrow's lecture we will also go for the dental history and examination. It's easy. This is very easy. We'll just go in the first 10 minutes. So tomorrow, do not be late in the first 10 minutes of the class, because we will be doing dental